Wellens syndrome is a result of critical stenosis of the left anterior descending artery. There are two types of Wellens syndrome. Type A is characterized by biphasic T waves with a positive initial part and negative terminal part in leads V2 and V3. Also, it may be seen in all precordial leads. Type B is characterized by deeply and symmetrically inverted T waves in same leads as Type A. Type B is 3 times more frequent than Type A. Such ECG patterns are highly specific for stenosis of the left anterior descending artery. Their specificity is 91.6%. There are no other ECG signs of myocardial infarction such as pathological Q waves, significant ST segment elevation, or poor precordial R wave progression. Such ECG changes may be transitory or they may be detected for several days and weeks. It's a pre-infarction state. There is a high risk of the myocardial infarction in the next weeks. Mean time of evolution to the anterior wall myocardial infarction is 8.5 days from the onset of the Wellens syndrome. There are following criteria of the Wellens syndrome: biphasic T waves with a positive initial part and negative terminal part, so-called Type A, or deeply and symmetrically inverted T waves, so-called Type B. No ST segment elevation, or less than 1 mm of ST segment elevation. No pathological precordial Q waves and no poor precordial R wave progression. Recent history of angina, ECG pattern presets in a pain-free state. It's important that Wellens syndrome is not an electrocardiographic feature, it's a clinical syndrome. Usually, ECG pattern of the Wellens syndrome appears after a transient ST segment elevation in the precordial leads due to sudden occlusions of the left anterior descending artery. If spontaneous clot lysis occurs, ST segment descends to the isoline, but biphasic or inverted T wave appears and pain subsides. If coronary perfusion is unstable, pseudo-normalisation of T wave occurs. In this case, T wave become positive during re-occlusion. T waves usually are prominent and are followed by ST segment elevation and recurrence of the chest pain. And at the moment of spontaneous reperfusion, T waves become biphasic or inverted again. There is repetitive transmural ischemic reperfusion. If coronary blood flow is limited for a long time, STEMI develops. In the case of Wellens syndrome, cardiac biomarkers are normal or slightly elevated. Besides atherosclerosis of coronary arteries, ECG pattern of Wellens syndrome presents in the following cases: Takotsubo cardiomyopathy, coronary vasospasm, myocardial bridging, and coronary artery dissection. In these cases, pseudo-Wellens syndrome is used. Also, precordial T wave inversion occurs in the case of pulmonary embolism, hypertrophic cardiomyopathy, central nervous system injury, left ventricular hypertrophy, bundle branch block, Brugada syndrome, and arrhythmogenic right ventricular dysplasia. Patients with Wellens syndrome should be treated as unstable angina. In the case of well-timed percutaneous coronary intervention with reperfusion of the left anterior descending artery, the patient's prognosis is good. Significant morbidity and mortality may be avoided.